The visual ocular reflex is a reflex providing motor output to the eye muscles to stabilize gaze during head motion. Information is received from the inner ear regarding head motion, and for every degree the head is turned in one direction, the eyes move in an equal distance in the ipsilateral direction. The three tests used to determine the function of the VOR are the head impulse test, head shaking nystagmus test, and the static versus dynamic visual acuity test. Because VOR testing requires an adequate amount of head motion, a quick past medical history and range of motion screen should be performed to the cervical spine. The purpose of the head impulse test is to assess the patient's ability to fixate on a visual target during quick, unpredictable head movements. Because the function of the VOR can be affected by lenses, the patient should be wearing their normal contact lenses or glasses during this test. Holding the patient's head firmly between your hands, the clinician should first perform a slight chin tuck of approximately 30 degrees to adequately stimulate the horizontal semicircular canals. To assist with the chin tuck and observe the patient's eyes, the clinician should position themselves slightly lower than eye level to the patient. The patient should be instructed to maintain gaze on the clinician's nose during the entire test. If the patient complains they are unable to focus on the clinician's nose, they are able to fixate on a more distant object during the examination. This is quite common in older adults. Begin by gently turning the patient's head side to side, feeling for when the patient becomes more relaxed. Then perform a quick, small amplitude thrust in each direction. As the clinician performs the thrust, they should be observing for the inability of the patient to maintain gaze on the target, evident by a correction saccade when the eyes quickly refixate to the target. The test should be performed with multiple, unpredictable thrusts in each direction. It is important for each thrust to maintain unpredictability to eliminate the patient's ability to compensate. A normal head impulse test would be when the patient is able to maintain fixation on the target, with an abnormal head impulse test being evident by a refixation saccade. With an abnormal finding, it is important to document the direction of the head thrust to determine the affected side. For example, if a correction saccade is observed when a head thrust is performed to the right, a right vestibular hypofunction would be suspected. The head impulse test can also be performed within the vertical plane.
Okay, so you said you were having some dizziness and some blurred vision whenever you were turning your head or whenever you turned your body. You have a reflex that works on your eyes. It's called a VOR that steadies your eyes whenever you move your body. There are 3 tests that we use to assess if it's working correctly, and it's controlled by your inner ear. So if you have one side of your inner ear that isn't working correctly, you can get this blurred vision. So the first test is called the head impulse test. I'm going to move your head side to side and then give you a quick thrust to see if you can maintain your eyes on the target. Okay. Can you look up and down for me? And side to side. Do you have your normal contact lenses in? I don't wear contacts. Okay. So if you can look at my nose.
The head shaking nystagmus test is administered to assess the function of the inner ear bilaterally to determine if there is an imbalance. Begin the test by first removing the patient's glasses if worn and don Frenzel lenses. Frenzel lenses are special goggles worn to block gaze fixation to ensure accurate test results. After approximately 2 weeks of developing a unilateral hypofunction, a patient can begin to compensate for the diminished vestibular function through gaze fixation to override the inaccurate information being received from the inner ear. When vision is blocked, the vestibular system takes over and the symptoms reappear. After Frenzel lenses are donned, grasp the patient's head and perform a chin tuck of approximately 30 degrees to adequately stimulate the horizontal semicircular canals. The clinician will then proceed by shaking the patient's head side to side 20 times at approximately 2 Hz. At 20, the patient should be instructed to open their eyes so the clinician can observe the occurrence of any eye movement. In the presence of a unilateral hypofunction, nystagmus would appear for 3 to 10 seconds in the form of quick beating horizontal eye movements. In the presence of a unilateral hypofunction, the quick phase of the beat will occur away from the hypofunctional side. However, when naming the nystagmus, you identify by stating the direction in which the fast beat occurs. For example, a patient with right beating nystagmus would have a quick phase to the right, indicating a left vestibular hypofunction. In the absence of vestibular hypofunction, the inner ear would be stimulated evenly on both sides, and no nystagmus would be observed.
Okay, so the next test we're going to do is called the head shaking nystagmus test, and we're going to put on these fancy little goggles that we call Frenzel goggles, and they're going to help me see your eyes better, and I'm just looking for any abnormal eye movement. I'm just going to be shaking your head side to side 20 times, and when I get to 20, I'm going to tell you when to open your eyes, and just open them so I can see. Okay, can you put these on? Okay, and open. Good.
The static versus dynamic acuity test is performed to assess gaze stabilization during movement. The patient should be positioned standing 20 feet away from the Snellen chart with the clinician standing behind them. If another standardized vision chart is used during this examination, the distance should be conformed to the parameters of that specific chart. The patient should first read the lowest line possible on the Snellen chart with both eyes open. Grasping the patient's head, perform the same chin tuck as described in the previous test, and begin to shake the patient's head side to side at approximately 2 Hz. During head motion, the patient should read the lowest line possible, beginning at the big E and working their way down. A normal test would be indicated when the patient is able to read within a 1 to 2 line difference between the static and dynamic acuity. An abnormal test would be indicated by the patient having a 3 or greater line difference between the static and dynamic visual acuity, indicating an impairment to the VOR.
So the final test we're going to do is called the static versus dynamic visual acuity test, and its purpose is to see how your reflex works in static situations versus dynamic situations. And can you read the lowest line possible? FDPLTCE O. I'm going to come behind you, and I'm going to shake your head, and I want you to start at the big E and read down as far as you can. E F P T O Z L P E D P E C F D E D F C Z P F E L O P Z D D E F P O T E C L E. I can't read that one.